Hello, my name is Cindy Asbjornsen, and I'm here at the Maine Osteopathic Association's annual convention to talk about aging and vein health. So my first slide is my biography. And what I want to point out is that we have a new address, 35 Foden Road in South Portland. We moved across the street. But I point that out because it's a reminder to extend the invitation to everyone here, anyone interested in vein health at all, to come by, come for an hour, come for a whole day, come see what we do and see our practice. It's interesting. My next slide is who I am, what I do, and why. And just a brief overview, I opened my practice, the Vein Healthcare Center, 11 years ago. And when I did, I had 3 goals. The first was to provide excellent care, which I'd like to think I do along with my team every day. The second was research to further the field of philology because it's a relatively new field. And we as a group have done a great job making annual contributions and currently just got approved to be part of a multi-center trial, a big national trial, comparing 2 common modalities head to head, which will be really interesting and should be starting soon and coming out in 3 or 4 years. And lastly, education. Not just patients in my community, but my fellow providers as well. And that's why I'm here, and that's why I extend that invitation. If any of you ever have any questions, concerns, just need a quick curbside about anything, my team is really great at tagging me between cases or grabbing a number and having me call back. So please never hesitate to reach out. Disclosures, I don't have any. And then my objectives. During this presentation, hopefully you'll be able to learn how to best recognize venous disease in our elderly population, understand options for improved vein health and some of the barriers to care, especially in the elderly. And then lastly, have a new appreciation for both conservative and definitive vein health options. So starting off, what is venous disease? Simply put, we have 2 big groups of venous disease. Obstructive, which is usually from clotting and sometimes from compressive syndromes like May-Turner's or nutcrackers. May-Turner's is when the left iliac vein is compressed by the right iliac artery, or nutcrackers when either the superior mesenteric or the aorta actually compress the left renal vein. And then our second type is insufficiency, which is usually from valve failure. So that's what we're going to be focusing on today. And epidemiology, who gets these kind of vein problems? Well, about 80 million Americans suffer from some form of venous disorder. Venous disorders are the most common cause of lower extremity ulcers. And we estimate 7 million people in the US have been diagnosed with venous insufficiency, of which at least 1 million will go on to develop an ulcer. So simply put, who's at risk? Pretty much everyone. And why is recognizing how vein disease presents in different age groups important? Well, every age group has similarities and differences. Oftentimes the same problem can look very different at different ages. And what I mean by that is when a valve breaks, whether you're 15, 50, or 95, it's the same problem. But if it broke when you're 15, you might notice one thing, and that thing is going to be different when you're 50, or even more different when you're 95. So as the disease progresses, it can look pretty different, even if we're dealing with the same exact problem. The other thing is treatment objectives are often different with age. Signs and symptoms might look different. And age perception also contributes to overall presentation. So a big part of treating veins is establishing a goal. And again, goals can be different at different ages. So as we break down each different age group, we'll start with young women or women between age 14 and 40. And I know this group could be broken down pretty much by decade, and women between 14 and 40 tend to be very different. But overall, there are some very similar features in this group as they present. They often do come in with symptoms like pain and aching and fatigue by the end of the day. But this particular group in my opinion, has the biggest psychological impact. And I say that because the disfigurement from venous disease can actually affect these people's activities. This is the group that oftentimes won't want to go to the beach. They won't take their children to the beach. They won't wear shorts. They won't wear any kind of clothing that exposes their legs. Of course, not everyone in this age group feels that way, but it's a common theme and we see it regularly. These people will actually go out of their way and miss life opportunity to avoid exposing their leg. And again, not everyone, these are sweeping generalizations, but it's quite common. Our next age group is men, 14 to 40. It's interesting that men come in for a little different reasons. Usually, these are men who only come in when they have an event that affects them at work, usually a bleed or an ulcer that's preventing them from doing their work. And I see it very commonly in men who work in restaurants, chefs who in the middle of a busy night will get a bleed and all of a sudden they'll look down and they'll be standing in a puddle of blood and they'll have to stop. And that's something they just can't do when they're at work. And, they've got all these orders that need to go out. They literally can't stop, but they have to. And when they stop, everybody stops and they all have to take care of the person who's bleeding. And it just literally stops a big production in its tracks. The other common profession I see are people who wear rubber boots, like fishermen, who again, just can't stop their day. When they're out on the water and they look down and their boots full of blood, they can't stop and rest and elevate and put pressure on it. And they don't have simple access to help. So those are my two big male groups who tend to come in for treatment. I'm sorry, let's skip to slide. My next group is women who are a little bit older, ages 40 to 65. For this group of women, a lot of times their children are growing up, if they have children. A lot of times these women are still working and they really want to focus on their health. They really want to feel good and they're starting to get concerned about mobility, about clotting issues, and their overall health, big picture health is usually the thing that drives them into the office. They're not always, but they're usually appreciative of a cosmetic improvement, but that's not why they come in general. The next group, being men, 40 to 65. These are a different kind of man. They often come in when their domestic partners complain or when their skin and symptoms start to affect other things that they're doing. These are oftentimes corporate folks who have spent a lot of their careers sitting for long periods, and they come in almost more annoyed with their problem than debilitated by it. And then finally, we get to our seniors. And in our seniors, I always like to think of seniors in three big groups themselves. So I'm going to combine men and women here, but I'll say the first group, ages 65 to really 74, the young old, come in wondering, am I too late? And the next question is always, will Medicare cover this? The second group, again, defined by the question they ask, the second group being 75 to 84, these are the folks who come in and say, should I bother? Or isn't this just normal? Do I have to do this? And then lastly, my 85 to 95-year-olds, they come in, and I should just say 85 plus because I have several patients who are over 95. They're the firecrackers. They come in and maybe this is what got them to this point, or maybe it's a new perspective, but they say, yeah, why wouldn't we treat this? Let's just do it. Let's get me as good as I can be for as long as I can be. So how do people present? This is an interesting one because a lot of times by the time we see a senior, they've had a problem for a while. And what I mean by that is, this problem might have started when they were much younger, and it might have given some mild symptoms and might have had the appearance of some bulgy veins. They come in and they say, yeah, I've got this new ache. It's horrible. It gets to me by the end of the day. I feel like I just need to sit down and rest. And as a provider, if you comment and say, oh, geez, this could be your veins, they're quick to say, oh, no. I've had that bulgy varicose vein for years. That vein doesn't bother me. but the reality is it's likely the progression of that vein. The other one is when folks come in, as you march through the progression of venous disease, one of the early signs for stage 3 in our SEEP classification is swelling. And when people start to swell, they do get concerned, but if you can see some bulging varicosities through the swelling and you say, oh, I think this could be your varicose veins, they're going to say, oh, no, it's definitely not my veins, because my veins have never looked this good. They used to be big and bulgy, now you can barely see them. And they don't realize that it's the swelling that's actually hiding the veins. Lastly, when folks come in with neurologic symptoms, and I think providers might say, hey, this could be your veins. Patients are very quick to say, oh no, restlessness, cramping, that pins and needly feeling, I think I need a neurologist. So it's important to recognize that even though veins have been there for a while, they can still be our culprit. So next I want to just say a couple quick words on barriers to vein care. Even if we can convince a patient that it is the vein that's their problem, sometimes we have other barriers. Sometimes practitioners themselves are the barriers. And I completely understand when patients come in and say, well, I brought this vein up to my primary care doctor, but they said not to worry about it. And they said, it's really not in my best interest to get any kind of treatment or evaluation. So I think that comes from a place about 23 years ago. We didn't really have great treatments. We didn't have great imaging modality. And a lot of times treatments were painful, unpleasant, and did cause some other issues, and oftentimes just weren't successful in general. But since the advent of modern phlebology and newer techniques, along with the imaging modalities we have, treatments are completely different. They're simple, they're easy, they're highly effective, and they really work. The other thing I hear regularly as a barrier from a provider is when people say, oh yeah, I told my doc about that vein and they assured me it was just cosmetic and that this was normal with aging. And kind of always pause and smile back. And I think about an interview that we did for our magazine, Vein Health News, with a very wise gerontologist named Bruce Bates. And one of my favorite quotes from that article was something that Dr. Bates said that really stuck. And that was, the acceptance of decreased functionality is as normal is a detriment to healthy and successful aging. And I just think that's so beautifully, eloquently put, that if we just accept things as, oh yeah, this is normal with age, it's a detriment to healthy and successful aging. So other barriers include travel. I am one of the few board certified phlebologists in the state, and I am the only fellow of phlebology. And with that, I have a lot of folks who travel from really all over. I mean, Canada, Vermont, New Hampshire, and just coming down from Fort Kent or Fort Fairfield, it's far. And when you're 98 years old, that's a heck of a trip. And sometimes it's just too much. And I completely understand that. So my little plug for, we need more vein doctors out there. But travel barriers are real. So why is it so important that we actually treat these people, or at least connect with these people so we can offer some type of care? We've known for a long time that venous disease is detrimental. There was an excellent Finnish study that just got published last year, and it beautifully defined the association between chronic venous disease and measures of physical performance in older people. It had over 500 participants. They were all between 70 and 92 years old, and they were evaluated by presence or absence of venous disease based on skin appearance, not ultrasound. So if you could see the skin changes associated with SEEP classes 4, 5, and 6, or if you had bulging varicosities, then you were considered positive. Otherwise, you were considered negative. And the physical assessments included getting up out of chairs, gait speed, and balance tests. And they definitively found people with venous disease had less ability to perform physical activities. The other important association that we oftentimes make with venous disease is clotting. And I put this study up. It's a little, well, it's getting dated now. It was published back in July of 2009. And it was one of the earlier studies that looked at the true association between superficial thrombophlebitis and deep vein thrombophlebitis. And it only had 46 patients, but they were 46 patients with what we considered non-worrisome superficial thrombophlebitis. And what they found is when you did an ultrasound, a typical rule-out DVT study in the hospital, they found no DVTs. But when you looked more closely at the entire deep system, meaning calf veins and some of the harder to see points in the femoral vein, we actually found more deep vein thromboses. Of the 46, 11 ended up having incidental finding of deep vein thrombosis. And this study sparked, I mean, it was obviously a pilot study, but it sparked a lot of interest in looking closer at the actual mechanism of venous disease being a risk factor. And right now, varicosities are considered a minor risk factor for deep vein thrombosis. But what we're seeing is the turbulence from that superficial system when blood's going up in a deep vein and changes directions in a superficial vein actually has kind of a rippling effect where that turbulence is carried out in other areas and can really be a bigger risk factor for clotting than we had once thought. A lot of this is still getting worked out, but we know definitively treating venous disease will decrease incidences of deep vein thrombosis. So how do we treat venous disease? What are the care options? I think the most important thing of all care is your diagnosis. And care with venous disease starts with ultrasound. We need to find out where the problem starts, how big it is, what it looks like, how much backflow we're seeing, and then treatment has to start at the source. The second thing is treatment has to be matched to our patient's goals. Which again, by age can be highly variable. And lastly, care can include just one small treatment, or there can be a multimodality approach. So every care plan has to be individualized to the patient. So in terms of using ultrasound to find the problem, a couple of important things is that first is that the patient is standing, not sitting. Gravity has to be at play, and a tilt on a table just isn't enough to actually close the valves we're trying to test. So if we try to order a mapping valve study from, say, your local hospital that doesn't do them regularly, oftentimes we'll get false positives and false negatives. So sending your patients to a vein center or to a facility that does mapping valve studies frequently is really probably one of the most important parts of their vein care. Unfortunately, there are not many people with the credential of RPHS in the state. RVTs are registered vascular techs. They're sort of the second best people to do this, but a registered phlebology sonographer is really kind of what we want in terms of evaluating vein patients. So what happens when you don't get the right spot? This is kind of important, and I'll talk you through this picture here. What you can see in the main column there is blood going towards your heart. And when you have a broken valve or a problem with venous disease, venous insufficiency, you have usually a broken valve at a junction that allows the blood to go in the wrong direction. So if you can find that spot and treat at that spot, meaning seal the vein shut right there, you're all set. If you don't find that spot, or you get a spot downstream and think you're at the right spot, maybe the patient was lying down, or maybe their anatomy is complicated, if you treat down a little bit, what happens is you seal that spot shut and all the backflow just shifts over to the vein that's left behind. And this is what used to happen commonly with strippings. We didn't strip right at the source of the backflow. We often started a little bit lower because we didn't have imaging like we have today. And what would happen is we'd leave a small small area of backflow, and just like the Grand Canyon, it would get bigger and bigger and bigger over time. So definitely not starting at the right spot can cause more problems down the road. So in terms of treatment, compression really is a mainstay. It's always an option, no matter who you are, where you are, how old you are. And oftentimes, as you start to get older, compression becomes a wonderful option. If you're 20 years old and you have a big painful varicosity, you might not want to make the kind of commitment that it takes to wear compression regularly, and you might be more interested in definitive care. But when you're getting on in years and you're really just looking for comfort and you have time to don and doff these garments, it becomes a lot more palatable. So I have many patients who we manage with long-term compression. The important thing with compression is that it's comfortable, it's not restrictive, and patients actually don't mind wearing it. Along with conservative management, we oftentimes include exercise and elevation, remembering that that calf muscle pump is really the heart of our venous system. Sometimes just getting people to walk 30 minutes a day can make the world of difference in terms of their symptoms and their overall pain health. Lastly, elevation. Gravity is our friend. If we can get that leg up 3 or 4 times a day, ideally higher than the heart, oftentimes that's enough to control symptoms. Nutraceuticals. We have a wealth of nutraceuticals, but like all nutraceuticals, they only work while you're taking them. They tend to not fix the problem, but more control symptoms. And lastly, they have to be what you think you are getting. So the 2 most common on that list up there are really horse chestnut seed and diosmin. Diosmin is a rooticide, and it's not quite as well known, but we actually have some of the best research supporting its ability to help overall vein health. Other options, generally speaking, when we treat veins, we try to seal them shut. The most common vein we seal shut is the great saphenous vein. It's generally a larger diameter, higher pressure vein because the flow is coming off the femoral into the great saphenous. And our current gold standard is no longer stripping, but instead an endothermal approach, which is a very, very easy small office procedure where patients walk in, walk out, and are in the office for about an hour. During that hour, we simply place a small micro-access kit, thread a fiber optic through the vein right to the spot where healthy flow meets unhealthy flow, add a little numbing medicine to the outside of the vein, tilt the bed so the head's lower than the feet, and then turn the heat source on. The 2 most common endothermal ablative techniques are laser and radio frequency waves. We tend to use the radio frequency waves on some of the larger veins and with the straightest channels, and then the laser has a more flexible fiber, so that can be used on some of the veins that have a little more bend and twist. Other options for treatment include super glue with cyanoacrylate, Verathena chemical ablations, and we also have mechanical chemical ablations. And all of these techniques are minimally invasive and aimed at sealing a vein shut based on where it starts to backflow, how big it is, and how much backflow we see. There's also many adjunctive therapies, the most common being sclerotherapy, which can be introduced either with ultrasound guidance or with light assistance, depending on how deep or close to the skin the vein is. And we also have liquid and foam versions of the injectable medications. So treating downstream, why is it so important that we have to find this oh so critical spot with ultrasound before we start treating? Well, simply put, if we don't, we run the risk of making new or worse problems than what we have right now. To explain this, I'm going to leave screen sharing and try to draw a picture on this board behind me. So demonstrating that picture that was on the screen when we clicked away, if you have your heart at the top of the screen and a healthy vein carrying lots of blood towards your heart, remembering that vein has valves that are intact, that are opening and shutting with pressure. If it has a connection with the vein, with a broken valve, that's where the trouble is going to start. So even though this vein has healthy valves and we have a lot of flow at this level, if this valve is broken, we're going to have a drop off in flow here because the blood's going to change direction and go in every different branch that this vein has. You get the domino effect of leak upon leak upon leak. So let's say our ultrasound tech isn't able to find this exact spot, or the patient's lying down, or something else is happening where we don't get the right spot, we don't get that critical area. And the skin surface is right here, we can clearly see this big varicosity, so we decide we'll treat a little bit up and we'll treat right here. Remembering when we treat a vein, we literally seal it shut with whatever modality we're using. So if we treat there, you can see this backflow that's coming down just lost one of its escape routes. So it's just going to transfer over to whatever's left behind. So this one that had a little bit of backflow is now going to have a lot of backflow. This is why getting that source is so critical. If we treat right here, we know we're going to leave you with all of this flow heading towards your heart. So nothing but healthy flow moving in the right direction. I'm going to try to go back to shared screen now, and we'll see what we get. Okay. So management or care, definitive or conservative. In the world of veins, we try to divide vein care into two big groups, conservative and definitive. Conservative care doesn't mean doing nothing. I'm going to move right on to conservative first. But with definitive care, I put the picture of the toolbox up there because it's important to have as many options as possible to do the right thing for the problematic vein. So with conservative care, the mainstay of conservative care is actually compression. Compression. Compression is one of those things where it's not the right choice for everyone, but when it works, boy, is it a good one. Compression will stop the progression of venous disease, and it will control the symptoms commonly associated with disease. So in a way, it's perfect. Plus, the risk of while wearing compression is virtually nil. The most important thing with compression is that it fits well. And here's one of those things where the sizing of compression garments is truly unique in that instead of going small, medium, large, or regular pant sizes, we take circumferential measurements of patients' legs at different levels. And once we have all these levels, we plot them on a graph and we say, okay, this is the size stocking that you're going to need. And that doesn't take into account if that patient is 4 feet tall or 6 feet tall. So clearly there's some holes in the sizing theory. So what I tell my patients for the conservative management, for compression, for buying their first pair of stockings, is when you buy them, make sure you know the return policy. Buy them, try them. If you don't like them, return them and try again. Some of these stockings, some brands will run long, some brands will run short, some will be high-waisted, some will be low-waisted. There's 101 different cuts out there. And there's a different one that's going to be right for every single person out there. I have some patients who will say, oh, I could never wear compression stockings. I have GI issues. I can't stand any pressure over my belly. I always tell them, well, there's 2 different maternity cuts. One is kind of a high rise that goes, oh, it's designed to go over the baby bump, and the other is a low rise that's designed to sort of hug your hips and go lower than the baby bump. The nice thing about the low rise ones are they have a very nice, soft, gentle elastic band that don't roll. So they're a nice option. I have some folks who say, oh, I could never wear compression stockings all the way up high. I have to go to the bathroom too much. Well, they make chap style where you don't even have to pull them down to go to the bathroom. There's other people who say, you know, I can't find any, they're all too long. And I encourage them to look for brands that make a petite cut. There's some people who say, geez, you know, no matter what I do, they bunch up behind my knees or in front of my ankles. And, you know, all of these fitting issues, they're all exactly that, issues that can be worked out. So finding a good fitter in your community who can work with patients if they're going to manage conservatively is imperative. Getting patients in a pair of stockings that feel good. You know they fit when they feel good. Imperative. Best way is to have them try on a whole bunch of different brands and be able to return them if they don't like them. So although it's hard, I think patience and persistence can get people into a comfortable pair of stockings that can really be a game changer. Along with compression, when we talk about conservative management, we talk about elevation, and elevation can mean a lot of different things for a lot of different people. Generally speaking, the rule of thumb is 3 minutes of elevation with your feet higher than your heart 4 times throughout the day is enough to control the average person's symptoms. This isn't perfect, but it really does make a big difference. And then lastly, exercise. We oftentimes in the world of veins talk about your calf muscle being the heart of the venous system, meaning as the blood leaves your arterial side of the equation, passing through the little capillaries, the pressure is virtually nil. So we need pressure to get that blood up against gravity to our hearts. And the way we do that is with calf muscle contraction and relaxation. So for some people, conservative management can consist of calf muscle pumping. Walking is a great way to get those calf muscle pumps, or just tapping your toes, tapping your heels, and you know, anything that moves that foot up and down is going to squeeze and relax that calf muscle. So all three, exercise, elevation, and compression, can be game changers for some people in terms of controlling their symptoms of venous disease. Again, most people in their younger years really aren't that interested in making the kind of commitment it takes to donning and doffing compression on a daily basis. But as people hit different points in their life, sometimes compression is or conservative management, I should say, is a perfect match for end game goals. And this is where it goes back to asking patients and listening about what they want out of their vein health and any treatment options that we can offer. If someone really doesn't want to jump into definitive care and they're looking for something a little different than our classic conservative management, sometimes nutraceuticals can be an option. Nutraceuticals are great when they can be acquired and taken the way we'd like to. We have quite a bit of research in the world of veins on commonly used nutraceuticals. The two most common on my list up on the screen here are horse chestnut seed extract and diosmid. Diosmid is in the family of ruticides and probably has the best research, mostly European studies, on its effectiveness in terms of helping vein health. The challenge is, generally speaking, that you have to take it for about 8 weeks before you see any relief in symptoms. And of course, like many nutraceuticals, if you stop taking it, you lose the benefit that you had while you were taking it. And then lastly, because nutraceuticals aren't regulated in the US, we always have to hope that people are actually getting what they think they're getting in terms of taking it. But on the Vein Healthcare Center's website, we have a section called Alternative Therapies, and all nutraceuticals with, I shouldn't say all, The most common nutraceuticals with any type of research showing any sort of benefit for vein health are listed, and they're listed in the order of the research that we have that support their use. So it's worth checking out, definitely worth a read, and an interesting way to help people who are willing to make the commitment to acquiring and taking nutraceuticals. So when we get into more definitive care, we have many treatment options, and the world of phlebology is exploding a little bit in terms of the options that we have. I feel like every conference I go to, I'm hearing about new things, new research, new cutting edge treatments. But generally speaking, I can say with confidence, the endovenous approaches have become our gold standard, meaning no more strippings. And I won't say completely no more, but I can say I have not done any type of phlebectomy in the past 11 years, which is pretty great. When it comes to endovascular approaches, we have many options. The most common are endothermal approaches, which are the radiofrequency and the endovenous laser options, which are very, very simple procedures with patients walking in, walking out, being in the office for about an hour. During that hour, after we get them all comfortable on the table, we do a full sterile prep. Then we use a small needle, usually a 32 gauge needle with buffered lidocaine, and we numb their skin, and then we place a small micro access. The nice thing is the only discomfort that's really associated with this procedure is that numbing of their skin, because once we have our micro access kit placed, there's no sensation on the inside of the veins. So for both of those endothermal approaches, once we have access, we simply slide a very small fiber optic through the vein right to that critical spot where healthy flow becomes unhealthy flow. It's very easy to see with ultrasound because the veins are jet black and our fiber optic is bright white. Once everything is all positioned, we simply tilt the patient so their feet are higher than their heart with our tilt tables. We add tumescent anesthesia, or very dilute anesthesia around the outside of the vein, which does three things. First, it compresses the vein walls hard against our fiber optics. Second, it actually creates a heat sink in the event there were any extra heat, and all the structures close by the vein are floated away and insulated by this extra fluid. And then the third thing it does is it provides a nice anesthetic effect for the patients, so they don't really feel anything at all with our fourth and final step when we turn the heat source on and slowly pull it back towards our IV access. In doing so, the vein literally seals itself shut, stopping the backflow of the deep to superficial reflux. Patients, like I said, walk in, walk out. They're in the office for about an hour. Post-operatively, the most important things are just that they walk 30 minutes every day and wear compression for 2 weeks. So overall, pretty uneventful. The other techniques, which are similar in effectiveness, little newer to the scene, the first is cyanoacrylate or superglue. This one has been FDA approved for about 5 years, but we're still getting new data. It's extremely effective. The big bonus with it is that you don't need to wear compression stockings post-operatively. The downsides are that it tends to take a little bit longer while performing it. And there have been some allergic reactions to the glue. So I think that might be one of the deterrents, or why it might not have quite taken over the popularity that the endothermal techniques have taken over. Mechanical chemical ablation, where we actually use a device to scratch the vein wall on the inside and then shower it with sclerosing agents. And then lastly, true chemical ablation, where we use proprietary foam to seal veins shut. All of these options have changed the landscape of how vein treatments are performed. They've given us great options for different size, different morphologies, different pressures in vein treatment. And each of them brings something new to the field in terms of how to best care for patients. Always have the same end goal, which is stopping the backflow right at that critical level where health becomes disease. This is just a quick before and after shot because people ask me all the time, do the bumps really go away? And I have to say, yeah, they do. It's not instant. Oftentimes the first 2 months, you don't see dramatic improvement in the visual appearance. Instead, people will come back really at the 2-month mark, very, very happy. Their aches, their heaviness, their fatigue, all of the symptoms associated with their venous disease just slowly fade away. And most people feel great at that first 2-month visit. And they'll oftentimes say, yeah, I feel wonderful, no regrets about doing this, but they don't look that different. And I'll say, yeah, I know. And then between 2 and 6 months, once their immune system actually has a chance to start reabsorbing those downstream veins, that's where we really see the big changes. And then the last 6 to 12 months, it's usually more reabsorption of just the smaller veins. So adjunctive therapies, sometimes once we treat primary source, there'll be smaller secondary veins that are also contributing to the problem. At that point, we don't need the endovascular approaches. We can usually get away with more simple treatments like sclerotherapy. With sclerotherapy, it's an old treatment that's been around for years where we just basically inject veins. The big difference is the injectables that we have at our fingertips today. They are effective, they are safe, they are easy to work with, they are well tolerated. The most common sclerosing agent today is polydocanol, which has antimicrobial effects, so it couldn't cause an infection. It's basically considered hypoallergenic, so we don't worry about allergic responses. It has mild anesthetic qualities as well as being pH balanced, so it's virtually painless on injection. So our sclerosants have not only become more tolerable, but also more effective. We introduce sclerosing agents in really 2 ways. The first is with ultrasound guidance in the event that the vein is a little bit deeper. We want to make sure we are getting it right at the junction of where the trouble starts. So we'll use ultrasound guidance. The second way is if it's much closer to the skin surface where ultrasound images tend to get a little more distorted, we can use handheld lights or we can use polarized lights, which will help us literally see through the skin to where the veins are lying. Either approach can be highly effective, again, depending on how big the vein is and where it lies. So I have one case study that I really wanted to share with you, and I was only going to share this if we had enough time, and it looks like we do. So back to clotting in venous disease. I was saying that a lot is happening, a lot is coming down the pike with new information, but one of the patients I wanted to share was a woman who I met about 8 years ago. She was 92 years old, and she was one of those firecrackers. She would drive from Florida to Maine every spring. She would camp all summer or live in a cabin at a KOA campground here in Maine. She would volunteer for the campground, painting picnic tables and trail maintenance and doing whatever she could to help out. And her heart was truly here. She loved Maine. She would have liked to have stayed in Maine her senior years, but she had such bad arthritis that she needed the warm waters of Florida to help her joints. So every fall, she would drive herself back down to Florida. The year I met her, she had driven up from Florida and her legs started to swell about halfway here, and she didn't know what to make of it, and she was scared, she was concerned. And when she got here, she went to the emergency department, and sure enough, she got diagnosed with a deep vein thrombosis. And this was the kind of woman who wasn't afraid of the internet. She jumped right on. She read everything she possibly could about deep vein thrombosis, and I think she probably Googled vein care in Maine, and the Maine Healthcare Center came up, so she called me. And she came in and she was visibly distraught. And she said, I'm a healthy 92-year-old woman. I'm strong. I, do all this great stuff. She's like, does this mean I can never drive from Florida to Maine again? Does this mean every time I do this, I'm going to get a clot? Does this mean, and she had about 100 questions, and they were all fraught with fear and all hallmarked by this was the end of a life that she loved. And it really broke my heart. And I, had a great conversation with her, and we talked about, what her risk factors for clotting were and why this could have happened. And we did an ultrasound, and sure enough, she had pretty significant deep to superficial reflux. What I mean by that is, again, another one of my little drawings. I'm going to switch from the shared view back to my drawing. She had beautiful, smooth, laminar flow in her deep veins. And as soon as I said laminar flow, everybody flashed back to physics, right? Remember laminar flow, we would talk about blood moving in a nice straight line without any kind of turbulence. So even though there's valves, which can be a little disruptive of flow, generally speaking, a healthy vein has smooth flow. I always like to think about a whitewater river. When a river is flowing smoothly, no matter how fast it's going, if there's no bends, no rocks, we don't see the rapids, we don't see the swirls and the whitewater. However, when you have a change in direction, when that river starts to bend, the blood literally swirls. I mean, the water literally swirls around the rocks. When you think about the whitewater river, as the river bends, or there's a rock in the river and the water's going around it, the water sits still. You always see the canoers and the kayakers sort of ducking in behind the rocks so they don't get flushed down the river. We call these back eddies. These little swirls are where the water in the river is sitting still, or where the blood in our leg is sitting still. When we have these back eddies, it's considered a clotting risk. And in the case of this patient, her clot probably started right where the blood changed direction. And because the valve was broken and the feed was coming from this area, the snowball was from superficial to deep. And that's what got her in trouble. So when I explained this to her, she said, okay, great, let's just take care of that vein. And like I was saying earlier, my 90 plus patients, they're the ones who say, okay, let's just do this. Let's fix this. I want to hold on to my health. So sure enough, after she was treated with anticoagulation for about 3 months, she had a nice channel of flow around the old damage. So we said, okay, let's go ahead and seal this vein shut for good. So we ended up doing an endothermal approach. We placed an IV, we threaded our little fiber optic, we numbed it up with the numbing medicine on the outside, and then we turned it on, pulled it back, and we restored her laminar flow. And I'm really happy to say that for the 5 years following that, she would drive herself down, drive herself up. Her last 2 years, I believe her niece drove with her, but she was able to resume the same quality of life she had prior to this event. And I feel like that's what vein care is all about. And just for the record, that same patient, after other health issues, decided it was time for her to eventually stay in Florida. And she used to check in with me annually. Now I get a card annually. And last October, she sent me a card and she thanked me for all of our good work. And she said she's really looking forward to her 100th birthday this October. So, you know, when people ask me, is it too late to get vein care? I'm 70. I always think about her. And, you know, even if we're just helping for a few years, even if we're just preserving vein health for a short period, it's still oftentimes truly worth it. With that case study, I'm going to just move on to my last slide, which is a quote from Andrew Taylor Still. And his quote reads, "To find health should be the objective of the doctor. Anyone can find disease." That one's always set well with me. So I will be here at the conference enjoying the Samoset. I'm available for questions anytime. I should have put my phone number on this final slide, but hopefully you all have a printout of these slides, or I'm pretty easy to find. But definitely reach out, ask questions, and I'll look forward to connecting with you. Thank you so much for listening to this presentation, and enjoy the rest of the conference. Take care.